Good evening, everyone. This is the last of our International Glaucoma webinar series, and today we will have on primary angle closure glaucoma, and during panel discussion we'll try to cover a little bit of secondary glaucoma. As usual, we have eminent international faculty. Today we have Dr. Shamira Pereira from Singapore National Eye Institute, and we also have Arun from Singapore Eye Institute, National Eye Institute. We have Ronnie Bhaskaran from Shankar Netralaya. I will introduce everyone later on. Warm welcome to all the delegates. And before we start, I will request Dr. Jignesh Taswara, who is the president of MOS, to welcome and start the today's webinar. He is the president of MOS, and we are doing the session under the aegis of MOS. Sir, please.
Thanks, Rajul. A warm welcome on behalf of the Maharashtra Ophthalmological Society. I see there's a series of glaucoma talks which are going on for the last 4 weeks. Very well arranged. Dr. Rajul and Dr. Shefali have taken real good efforts. And we have the star faculty, galaxy of stars, who are going to lead us on this topic. And we have the MOS people already who have joined it in a big way, and everybody is enjoying it. And I'm sure there is a go-home message for each and every general ophthalmologist who is going to be part of this webinar. Thanks for being under the aegis of MOS, Dr. Rajul. You can take over. Thanks a lot.
Thanks.
And a warm welcome to all of them.
So before we start the talk, I'll just introduce our faculty and the panelist. So Dr. Shamira Pereira is associate professor and senior glaucoma consultant at Singapore National Eye Centre, Singapore. He has more than 150 publications. His main research interest is the surgical devices and the imaging in angle closure, and he has tremendous publication and research work, and he will be talking about the future of angle imaging. The second is Ronnie George. I don't have to introduce. He is a well-known national and international faculty. He is director of glaucoma services. He is also director of the research at Shankar Netralaya. He also has more than 150 publications. Then as panelists, we have Thomas George. He is a senior consultant, Department of Glaucoma, Chaitanya Eye Hospital and Research Institute. And he was my first mentor, senior registrar, when I started my residency in CMC Vellore. Bhaskaran, he is also senior consultant at Shankar Netralaya. Before that, he also worked at SNEC. He also has tremendous research work. Arun is a senior physician staff, glaucoma consultant at Singapore National Eye Centre, Singapore. He is also well known, tremendous research interest in angle closure glaucoma. Dr. Amit Porwal is head Department of Glaucoma, Choitaram Netralaya, Indore. Dr. Kavita, she is a senior glaucoma consultant, Arvind Eye Hospital, Pondicherry. And Dr. Siddharth Dikshit is a senior glaucoma consultant, VST Center for Glaucoma, Ali Prasad Eye Institute, Hyderabad. Shefali and we will moderate the session. I welcome all the delegates, and I request Shamira to start his talk. Shamira, please take over.
Somewhat... You'll have to unmute yourself, sir.
Okay. Thank you very much for the kind introduction. And my only wish is that we were here in person rather than doing it on Zoom for this talk. But my talk is going to be on angle closure glaucoma diagnosis. And realistically, one of the main things that we're going to be speaking about is how to make the diagnosis of angle closure. And this is usually done with gonoscopy, but there are several problems with this, as we'll go through later on. And there's been a vast resurgence in the imaging techniques for this particular area. And I'll be going through with you one by one some of the various photographic and cross-sectional imaging techniques that are taking over now and will lead us towards, in the future, maybe some sort of automated gonioscopy in the future. These are my financial disclosures, none of which are relevant for today's presentation. So as we know, the reason why we do gonoscopy is to find out the state of the angle. This aids in prognosis and also in the actual diagnosis of the patient. The problem is with gonoscopy is it's a difficult skill to learn. It's not done very often, as much as it should be, and it can have a lot of artifacts as well. So there are various tools that have been used to help us with this. And some of them are, like we have on the left, the photographic imaging, which is very much like gonoscopy itself. And on the right, we have the cross-sectional imaging, like there's the Aesocity and UBM type images that we have on the right, like the Cassia. And these are the devices that are at the top of their game at the moment. I'll explain it in a while later on how we got there and the evolution of these particular devices. But those of you who may know the RetCam from its early days in pediatric posterior segment disease, diagnosing ROP, for example, we've utilized it again for the angle by applying it over some viscoelastic at the limbus and again some excellent non-contact images, as you can see here on the left. The Cassia, on the other hand, gives us cross-sectional images, much like we've seen before with our ASOCTs, but it gives us 128 meridional frames, 1.41 degrees apart, which enables us to get a very good view of the angle itself at different parts. And it gives us a graphical interface of how much closer it is. You can see that in the cross-sectional imaging below, that's a UBM, you can see there's a very obvious tilted disc, tilted IOL. Part of it is in the sulcus and part of it is in the bag. Now, when you look at gonoscopy, it's not so obvious, and you can see how the advantages of cross-sectional imaging show that basically it exaggerates the differences in the vertical meridians so that you can see those changes more easily. Yes, you can see on the gonoscopy that there is something going on there, but it's much more obvious on the UBM underneath. You can see here, there's been a massive improvement in the devices that we've been using, from the time domain devices originally, like the Visante, towards spectral domain devices, and then finally towards the swept source ones, which you have here, the Cassia 1, Cassia 2, and the Anterior. And these give us now a very good circumferential imaging. And these are some examples of the images that we can get with these devices. You can see as it takes various cuts through the anterior segment and recompiles it, you can get an excellent cross-sectional image in totality of the whole angle. The problem was in the past, when you did cross-sectional images, you only got a view of what was happening in that one particular meridian. If you moved a few degrees away, it could be completely different. And here's some of those, the way it divides those images up by tracing the area of the cornea, then finding out the area of interest and correcting it, and then finally giving us what we need to go and look at. And all those very many images in the end, in the 128 degrees. Now, as you can see, the quality of photographic image is excellent. It's almost like as if we were doing the gonoscopy itself. And you can see here the pale trabecular meshwork and the multiple iris processes. And you can see this in very good detail. You can even delineate the subtle angle opening that happens after an LPI. You can see that a closed angle here pre-LPI. On the right, post-LPI angle opening up. And you can see the pigment that's been deposited from the LPI as well. So it really does show as these subtle, intricate differences that occur after these procedures. Importantly, the light that's shining does not constrict the pupil, and it allows us to get a good view of the angle without artificially causing a change in the angle structures. We did a lot of research on this area, looking at how it compared with gonoscopy, and we found that there was a good agreement with AUCs or AC1 statistics in this particular case, around about 0.75 or so. In another paper, when we looked at a three-way comparison with gonio photos compared to ICAM, comparing to the gold standard of gonoscopy, we found they were actually very similar, and we weren't surprised at that at all, because in actual fact, they were doing the same kind of imaging, as opposed to ASOC, which is cross-sectional imaging. When we looked at the ICAM versus gonioscopy and goniophotography versus gonioscopy, we found AUCs of around about 0.93, which is actually very, very good. Based on these, we managed to go and actually divide our own system of automatic angle grading using RetCam images. We called it agate. Agate's a stone, as you can see on the left, and it's similar in striations to the view that we get from gonioscopy. And this is actually a real-time version of our agate program in working. What happens is you take images that have been taken from the RETCam and you load them up, and it automatically loads up as temporal, nasal, inferior, and superior if you tell them which eye is involved. Then once that's done, it will automatically take the area of interest, find out if the angle is open or closed, and give you a readout like this. And here's another one in real time occurring. And I'm very proud to have on the call with me today, Dr. Arun Narayanaswamy and Dr. Bhaskaran as well, who were also involved in a lot of these tests and studies as well. So here we have the actual results of the manual grading versus gonoscopy. You see the AUC is very, very high. The automated versus gonoscopy is also very, very high, 0.95. However, there are still problems, and it does still tend to overcall angle closure. Using different definitions of angle closure, you can see how the ICAM works out compared to gonio, and the Agate, the automated version, works out as well, slightly lesser. But it's still better than the Aesocity versus gonio. But yet, as of yet, we still don't know which is the most accurate, because, of course, these are all, there's no real gold standard apart from what we're using at the moment, which is the gonoscopic gold standard. Later on, we repeated some of these experiments by using an AI version of detecting angle closure instead of the previous machine learning one. And this was able to give us some very, very high AUCs, around about 0.96 as well. And you can see here, when you interrogate the eye, you can see that it shows the area of interest very clearly in those red markings. However, it does get it wrong sometimes, and you can see here where there's a poorly delineated scleral spur in image A, it doesn't get right, and it gets it wrong again in image B when there's a shadow interference, as you can see by the yellow arrow. Now, a lot of the problems that occur with imaging with, let's say, gonio photos is because it requires a lot of skill. You require the photography skills as well as the gonioscopy skills, and you need to know the angle structures, and there are certain problems because you can't indent as well. Because of these problems, we need to get some kind of automated system to look at photographic images, and Nidec stepped up to the mark. They created this machine called the GS1, and what it involves is several gonio mirrors placed on the eye, and it takes multiple images at one shot. It takes a bit of a while to do it, probably about a minute or so to take all those images. It does them almost like one by one, and then it stitches them, as many of you have seen, like as if you get a panoramic image from your phone. The problem is it doesn't give you so much depth of view for grading, and sometimes the images can be a bit blurry. I'll show you some of those later on. And it does require a good fixation and a reasonable patient. I've done it myself. I had it done on me, and the results were reasonable, but of course it did require being still and cooperating with the person who was doing the examination. This is actually my eye, and you can see some of the images here. And it gives you a fairly clear view, but the depth of field is not that good. It gives us a good circumferential view, but of course there are significant limitations because it does take a while to do. It takes a lot longer than gonoscopy. Here's the other eye as well, but you can see the clear structures here of the TM and the scleral spur and the ciliary body in this particular case. There was actually only slight agreement when you compared manual and automated gonoscopy in this one study by Texera, when they looked at the iridocorneal angle opening status. So it's a bit disappointing, I must say. But of course, this is just the version 1, and I'm sure in the future we'll have better ones to help us. Now, there is a real need for this automated gonioscopy because gonioscopy has several problems. It needs an eye specialist, there's some discomfort involved. It's actually very rarely performed, much less often than it should be. And there are compression artifacts and difficult for us to get some photo documentation. So here, when you have a possibility of getting a gonioscopic assisted surgery, there's a real unmet need. There's no need for a microscope here. You can get some excellent, no need for expertise, and you can possibly even use it for operations. And I'll give you some of our experience on this later on. We actually filed a patent quite a while ago now, and Bhaskar was involved in this as well, where we developed the gonio pen to look at the angle, and it's much smaller than the automated gonioscope, and it much more resembles the original RETCam, but it's much smaller, and it can be fed straight into a computer. The problems were, of course, that it has this light source that's involved. that gives us the fiber optic light to light up that angle. And that's quite bulky, and it has to go into a computer. So the idea was eventually after this was to try and make it portable and maybe even link up to a computer, ideally via Bluetooth. And Bhaskar was involved in most of these studies for the development of the Goni pen. And since he's subsequently gone back to India, I've been taking over trying to make it mobile. Now, the AUCs, as you can see here, have been pretty good, up to 0.97 in the diagnosis of PACG, closed angles on the Goni pen. But there are several problems with this device. Still quite bulky. It's very rudimentary in its design. It's not really very ergonomic. But there are some things that we can do. And that's what we tend to do to take it further to the next step. And you can see that diagram on the right there. You can see some of the images that we're getting now with this new camera, which links up to a mobile phone or a computer. And realistically, the tech here is taken from drones. If you can imagine a drone taking pictures, that's what it's doing, taking pictures of something remotely and transferring the images to your phone. But of course, the contrast is not really there. The depth of field is not there either. So it does require more work. We're getting high resolution images from better quality video apertures as well. So here you can see some of the images of the angle that we've done with the Goni pen versus the competition. The Goni pen is on the left-hand side here. It is a little bit washed out. You couldn't really get so much of the detail compared to the Gonoscopic gold standard or the RETCAM for that matter. But you can certainly make out the angle structures, and this is useful enough for us to make diagnosis. And if you can imagine the portability and the other advantages of this, this is really a big help. The NIDEC one is still not quite there yet. You can see the blurry images are still not so good. When you look at things on a comparison chart, you can see that the Goni pen does win out in a lot of areas, requires very little expertise, gives an automatic diagnosis of angle closure using our custom-built softwares, and also it allows for easy photography and documentation. It's also very small and space-saving compared to, I don't know if you've ever seen the RETCAM. It's a huge device. It's like a size of a phaco machine, and it's very cost-effective as well. In this case, undercutting even the gonioscopy. And I've actually used it to go and put in some devices in monkey eyes for MIGS as well. So it can be used potentially for surgery. Imagine that, being able to put in devices into the angle without even using a microscope and a gonioscopy lens that we usually use for MIGS. It's possible to do this for monkey eyes anyway, at least. It's difficult, but of course we need to optimize this for the longer term future. So thank you very much for allowing me to speak on my pet topic here, and I will welcome any questions at the end. Thank you very much.
Yeah, thanks, Dr. Shamira, for a nice presentation. We'll have lots of questions, and I'll request all the delegates they can ask the questions, and we'll take it later after the second talk. I request Ronnie to start his talk, and he'll be talking about the implication of recent RCTs in PACD management. Ronnie, please take over.
So, Rajul, I hope slides are visible.
No, it's not visible yet.
What about now?
Yeah, visible.
Oh, it is? Okay, sir. Okay. So, but it's not just
It's not visible
start
yet.
sharing once again.
Please.
Okay.
No,
Can you see that now?
No, not visible.
What about now?
Yes, visible.
Okay, so I'm going to basically start in the recent past, and they looked at different aspects of the disease. One, this looked at what happens between in angle closure disease, Eagle study. The other two, which looked at what happens in primary angle closure suspects. How does laser do in these two? Basically, is managed here. I just can tell you how we manage PSCs. So guidelines, which is the fluoridotomy is required for eyes. PSC and PAG, we consider the peripheral. and consider early lens extraction. Only cataract extraction goes with at least some visually significant cataract. A lot of feedback from somewhere.
Ronnie, your voice is breaking.
There's a lot of noise in the yeah. Is everybody's mic off?
Yeah, a lot of disturbance at the background, Ronnie, and the voice, we are not able to hear anything.
So let me say, and it's now the disturbance seems to have gone. Can you hear me now?
Ronnie, your slides
Amit,
are
is this better?
yeah, this is better, but still your voice is not so clear.
Okay, I'll just speak a little louder because I'm
Yeah.
not having this. Okay.
Okay, yeah.
So the study was basically peripheral iridotomy for the prevention of disease. And this was done in China. And essentially, they looked at two patients, one which had undergone LPI for glaucoma randomly, and the other was for PACS, and the other was assigned to iridotomy. And what they found was how many raised intraocular pressure, synechiae, or an acute angle closure attack. And they found that patients who had undergone a laser peripheral iridotomy, that is the blue line, were less likely to have any of these events as compared to the control sample. So when you look at was more 18 months follow-up as compared to the earlier period. In terms of risk factors, the risk factors were people whose limbal chamber depth was at least 10% more shallower, or central chamber depth was shallower. These were the reasons for which higher risk factor. So in summary, they say that incident disease occurred very rarely, and when it did, it appeared to be relatively benign in nature. However, the of laser PI was statistically significant, and they calculated an NNT that 44 need to be treated to prevent one case of disease over the 6 years with no effect on visual function. And I told you the definitions of progression here. So essentially, they said that there's not a great benefit for everybody with narrow angles. The another study, which three of whose authors are sitting here actually, was also asked a similar question, but the design was a little different in the sense that they randomized 480 patients in one eye, just follow up in the other eye. And this is better because a lot of the patient factors get taken off the equation once you do this. And when you look at this, again, you see that in the control group, you had less progression, either in terms of the laser formation, less chances of IOP elevation, less acute attacks, and less conversion to PAC. But these numbers were not pretty small in both. So per 1,000 eyes, it was 11.65 versus 21.84. Acute angle closure was very rare, only one event in the group, 2 events in the control group. IOP elevation was less common than the formation of synechiae. And that is, I think, one point that we need to take forward, going that you are not going to be able to detect progression unless you do a repeat gonioscopy. Risk factors here too, the age was after dilatation, for every 1 millimeter increase in IOP was associated with progression. Was a scale almost a 1.5 times difference. The hazard ratio was significant, so laser peripherectomy was significantly beneficial in reducing the risk of progression in this. In summary, they found, this is again quoted from the paper, they found that eyes with untreated gaze peripheral and synechiae over 5 with eyes that are lactic. And they said that their findings confirm what they saw in the ZAP study, further supporting the recommendation that observation without LPI is an option. Which is fairly large for us to consider treating everybody with an LPI. So in summary, should I manage PACS differently now from the way I'm doing it in India? Answer to that is no, because both studies actually give us evidence to support current protocols that not everybody with PACS we need to run in laser pyrotony. I'll switch gears and talk about the EAGLE study. And the EAGLE study basically spoke about the effectiveness of early lens extraction with IOL implantation for primary angle closure glaucoma. This was a randomized controlled trial. And the questions that we really wanted answered is, extraction improves disease control in terms of angle control. Does it help in widening the angle? Does it help with IOP? And does it help with disc or visual field progression? So the aim, their primary aim of this study was actually not, was to look at quality of life and vision in these patients. The secondary aims were intraocular pressure control and the stability of the disease and the safety of the interventions. And the duration of follow-up was 3 years after randomization. So the compared of care, which was usually laser PI followed by sequence of medical therapy and glaucoma surgery. A higher quality of life, a lower IOP, there would be a difference of 1.75 meters within the group and a 50% lower glaucoma surgery rate. And these are the inclusion criteria. I basically just focus on one thing, and that is that the people with AC who are in the group more than 30 millimeters of mercury to be eligible. So not every PAC could be recruited in the study. Exclusion criteria were fairly standard. They excluded other possible confounders.
Ronnie?
Yeah, I'm back. I'm sorry, my connection is very unstable because of some technical issues here. Yeah. Can you see my slides now? Raju, can you see my slides?
It is the first slide, yes. It is
The
first introduction, first slide.
Ronnie, we can see your slides. You haven't gone to slideshow. First slide is on.
Okay. So basically, now coming back to the exclusion criteria, they excluded symptomatic cataract in either eye. And then
Ronnie, your slide is not visible.
not now.
No, not yet.
What now?
No.
One minute. Just go and come back.
Just try to get trying to re-log in, or
No, I will just open the presentation and try.
no, Ronnie. Then his slide is not visible. It says that you have started screen sharing, but slides are not visible.
Just give it a minute. I think
Yeah, you want to re-log in, just see. Till then, I'll just take some questions.
Yes. Okay, I'll do that.
So till the Ronnie has some technical issue, he will re-log in. So till he comes back, any questions for Shamira? Or any Bhaskar, you want to give your thought process in the future of angle imaging, because you have done work along with the Shamira when you were in there, and
Yeah.
Arun also.
Yeah, I think most of that work is part of my PhD as well. So one of the things which we can see from the trial, what Ronnie has been talking about, the analysis and the ZAP, the progression is more of peripheral anterior synechiae and the angle changes only. Intraocular pressure elevation and progression or acute angle closures are not that much. So if we want to follow up, say asymptomatic angle closure or the angle closure disease, gonioscopy is important. And unfortunately, the practical difficulties are there. So if we can have such imaging techniques, which are, I would more bet on the photographic techniques. So if you are able to, get some imaging like that, which is cheap and effective, which can be done by a technician, that will be a good option actually. I'm talking only about patient imaging, not screening, because obviously angle closure screening is not yet a possible thing due to the prevalence and the progression rates what we have.
They're talking
It's not
about once you
advisable.
diagnose the patient of
Yes.
PSCs.
So diagnosis wise, I think I would think about goniophotography in terms of such small digital devices which are cost effective. That would be one of the simplest one. And of course, as Shamira said, if they can be used as a gonioscopy assisted surgical device, then it will negate the use of microscope. And many of these mixed devices can be used. However, I would put a word of caution, mixed devices have to be proven to be effective in many of these conditions. So I'm not talking just about angle closure in the surgery part of it, but generally. Okay, so those two places, those two things, the imaging will improve. But in terms of ASOCT, I think it is a long way to go. One of the reason is the cost of the device, and second thing, it has not yet proven to be a very good tool in terms of performance.
So agreed. I think 25% approximately images are usually not able to use.
Yes, so that is the next point. If 15 to 20% misclassification errors in our population, it will create a big number of patients coming to our clinics if we are going to do screening. I don't think it is advisable.
We talk about the gonio photographs and other imaging, but I remember I think you had publication few years back about the progression on Aesocity.
Yes.
So and I think
yeah, so the Aesocity progression is even before what happens with gonioscopy actually. So if those patients who have angle closure on Aesocity, actually Aesocity angle closure happens more before what we see on gonioscopy, probably because of the light conditions what we use for gonioscopy. And when we follow up these patients after 4 to 5 years, gonioscopy showed angle closure. But I'm not sure whether it is really relevant with the kind of progression rates that we are having. So I still do not know what is the significance of that, but it is a finding that we are able to share with the, the research community.
you would not recommend using Aesocity progression as an indication for intervention.
As of now, I don't think that is going to be on the cards because of the progression rates that you are seeing here in ZAP and analyst study.
Okay.
But I think an individual patient who is having symptoms, I think that would be one of the things to look at with ASOCT. Sometimes I do it. When a patient has a borderline angle closure on gonioscopy, I send them for an ASOCT. Sometimes you see the angle is completely closed, and it makes my decision easier to make a PI. It will justify it. But I think, at the end of it, if the patient is symptomatic and we are tending to have an angle closure, then we would go ahead with the laser, right?
Okay. I think we'll take this discussion after the Ronnie's talk. Ronnie, is your network stable?
Hopefully more stable. Let me just see.
Yeah, then let's try one more time.
Okay. See slides?
Yeah, can see your slides.
Yeah,
Okay.
Ronnie is visible.
Okay, so then I'll just continue from here. And basically, what they did is they randomized them to either lens extraction or to a laser peripheral iridotomy, followed by a combination of medical therapy with or without peripheral iridoplasty. And so surgery for the cataract or the lens extraction was combined with monofocal intraocular lens with or without synechial. And for the LPI, it was done within 60 days of randomization. Iridoplasty was up to the decision of the physician. And medications, they used the entire set of medications available to us except the ROC kinase inhibitors. They started with a single drop and escalated up to 3 drugs and used laser trabeculoplasty if needed. So the primary outcome, as we said, was patient-centered, the quality of life. Clinical was IOP at 3 years, and economic was also with the quality of life questionnaire. The secondary was patient-centered health status. Clinical, the secondary outcome was the extent of synechiae, the number of glaucoma medications and glaucoma surgery, and the need for glaucoma surgery. It was supposed to be done in 12 months and at 36 months. So hospitals and they enrolled about 419 patients, out of which 208 were assigned to clearance extraction and 211 to laser iridotomy. Some baseline data was not available in both groups of 5%. In terms of the results, the quality of life, the difference was 0.052. And intraocular pressure difference was 1.2 millimeters of mercury between these two groups. And this was statistically significant. So the conclusion of the study was that their results indicated that clearance for primary angle closure glaucoma and primary angle closure with increased intraocular pressure. But when you look at this, the primary outcome here is quality of life. And when you look at the two groups, you find that the refractive error difference between the clear lens extraction group and the LPI group is about 1.6 and 1.1 millimeters of mercury. That alone could have accounted for a difference in quality of life, because quality of life is definitely very vision dependent. And this difference of 0.052 is a very small difference. It's just a 5% difference on the quality of life index. And how much difference does it actually make to our average patient? In terms of IOP, the difference was just the study was actually designed to measure the difference of 1.75 millimeters. So this difference was even less than what would be the total that they would get. So this is a slightly busy slide, but I'll just show you these three groups. So when you look at the non-Chinese, when you look at PSC, and when you look at patients with better visual acuity, the quality of life was equal in both the groups. It was not significantly different in either group. And the same applied for PSC for intraocular pressure and for unilateral versus bilateral disease. So the results were not actually homogeneous across different groups or across different populations. So what about the angle? So gonoscopy without indentation was, this is the baseline gonoscopic characteristics. And I'll just talk to you about the final gonoscopic characteristics. At the baseline itself, we had missing data on synechiae for 247 people. And at the final visit, you had a huge amount of missing data on synechiae. For almost 60% of patients in both groups, data on the synechiae was missing. In fact, gonoscopic data itself was missing on 65% in the first and 50% in the second group. So my questions on clear lens extraction was, does it improve disease control? And in terms of the angle, we have no additional information on whether it improved angle control. In terms of intraocular pressure, there's a minimum difference in IOP difference. In terms of disc of visual fields, actually nothing reported and nothing significant seen. So will Eagle change my clinical practice of PSC and PSCS? No, I will still continue to do YAC-PI for everybody and in PSC and PSCG. And I would consider maybe removing an early cataract, but clear lens extraction for everybody is definitely not my take-home message from this. Thank you, and I apologize for all the technical issues I've been having.
So yeah, no problem, Ron. It happens. The internet connectivity sometimes is bad. Everybody faces, so no issue. We had two nice discussion. Before we open up I take the questions from my panel, my prepared questions or the delegate questions. If any panelists want to have any questions for Shamira, want to add anything for Shamira, Ronnie said, then we will take those questions and then I will start my. Thomas George, want to add? Arun, Arun. Arun is. So
Can I make
You were part of quite a few studies along with Shamira and Bhaskar. So let's start with you.
Please go ahead.
Your take on the future, and then your take on what Ronnie said.
Ronnie said about, okay, in terms of the angle need, I guess we will stand by gonioscopy as our method to interpret what we need to do clinically. When there's a discrepancy between two experts, that's when I tend to lean towards imaging for what we have, in terms of if two people disagree on what the angle status is, or if there's a patient education point of view, that's when I access imaging as an additional tool, or a tool that gives further information in terms of management. In terms of Ronnie, what would you want me to comment upon? Ronnie's.
So you were part of analysis, if I'm not mistaken.
Yes, so we all agree that the progression rates are low, and now we have evidence, and thereby a conservative approach is what we should lean towards. And I guess that's a fair point that is justified based on evidence.
So the one of the questions, lots of experts put that the ZEP trial excluded the high risk patient. That anybody who had the IOP increased by 15 millimeter mercury pre the first screening visit, they excluded, and that's why it cannot be used as a the data to validate that the angle closure suspect should be observed. So what do you think about that? When I looked up, I thought it was only one patient out of 11,000, and I thought that it doesn't make any difference if you have excluded only one patient. So theoretically yes, but practically I thought it was not any difference, and we can easily use this data. And when your study also came, so what do you think that one of that the question mark lots of people?
I mean, like you said, it's just one patient that is excluded, but at the same time, we should take a overall perspective of what the patient is experiencing. If he's really reporting symptoms, we need to add that risk factor into our assessment and what the patient needs. So that should also be a point to consider if we are dealing with a symptomatic patient. That we just don't go by the presence of extent of iridotrabecular contact, or and when we know that the angle is narrow, sometimes, like we said, on imaging, we find a lot of times the ASOC tends to say that the angle is closed, whereas on gonioscopy, when the contact is short, we do see the posterior trabecular meshwork. So our clinical decision maybe is not to do a laser PI based on these two aspects. But let's say the same patient is symptomatic and clearly reports symptoms that add on to the problem, then I guess it's a clinical decision-making standpoint wherein you probably would decide to do a laser PI. So it does not end with what we see on the image or what we see on the gonioscopy. There has to be a comprehensive evaluation of what the risk or what the symptoms patient's facing.
Okay. Thomas George, want to add anything? Have any?
I think Siddharth had something to ask.
Yeah, Siddharth, please.
Yeah, I was just following up what Dr. Ronnie said, and I wanted to reiterate the fact that the Eagle trial didn't mention the fact that it was performed by very highly skilled surgeons in that group, and that's why the complications were very few. I'm quite sure all of us see patients with complicated cataract surgeries where PI was not performed and the patient had troubles on the table. So cataract surgery as a replacement for PI, I think we are very, very far away from that.
I think in angle closure, even post PI, the cataract surgery is challenging. Not in all patients, but definitely in some patients. So that has to kept in mind that before we use the Eagle study into day-to-day practice.
Rajul, the analysis and ZAP are less threatening to us because laser PI has got very little complications. So we don't mind doing it or not doing it and watching. But lens extraction is an invasive surgery. Chance of complications is much more. And if you really look into the study, the Eagle study was not very well done. And that's very obvious. Plus, we've always maintained that just cataract surgery quite often gives us a 2 millimeter reduction in pressure, at least in the short term. So this also needs to be factored in. It's generally accepted by all cataract surgeons. Short term, you get a 2 millimeter reduction.
Maybe little more with angle closure patients. But
Absolutely. And doing a cataract in a shallow chamber is tough.
Yeah, we have to keep
the gonio pen, I'd like to make a statement. It looks promising. When can we expect it on the market? Because we are all into EMR. It does sound like something we can add on to it, which we can go back to rather than our written records of the grading.
Yeah, thanks for the positive comments on that. I mean, Bhaskar and I have been working on this for quite a while now, and there are still some hurdles to get over. But actually, you know, the quality of the images is really quite great. Imagine you could have something hanging on your slit lamp. You know, you could just take out and quickly take 4 images and you have the answer right there. It would really aid our diagnosis and prognostication.
So Shamira, I have a question regarding the gonio pen. How much illumination do you require to actually take an image?
How much was, sorry?
How much light do you need? How much light do you need to take an image?
Very little now. If you have a look at your own phone camera, the abilities of it to take images in the dark is excellent compared to what it was 10 years ago. So the same things have filtered down to these cameras as well. And we could possibly even get an infrared image, which would be brilliant. If you imagine that, an infrared image with no light whatsoever.
Yeah, because I think Ronnie, what you wanted to ask, that how much the pupillary constriction which can happen and open up the angle.
Right.
One more thing, is it a contact procedure? In which case, we can probably do an indentation also.
So the difficulty with indentation, it's not a contact. You put a blob of viscoelastic on the side of the eye and you just abut it. So you're actually not physically touching the eye. However, yes, we've thought about the ideas of like using an indentation with, let's say, for example, a cotton bud, you know, placed over the center part of the eye, or even a gonoscope, and then you take several images later. But I think for the moment, if we can just even get good quality images, you know, on all our patients that need it, that would be amazing.
Okay.
With indentation on that, the cornea gets distorted and your angle image gets suffered in that gonio pen imaging. But it is a possibility if we can have you know, some kind of a indentation touching with the gonio pen itself. It is a possibility, but I think it is a little bit far away.
Okay. So the most of our the attendees are general ophthalmologists. So let's have some general questions for them before we move on to the secondary glaucoma discussion.
I think Rajul, you should summarize the result of Eagle study, that ultimately what we have decided. When you're doing in angle closure, if the patient has cataract and you decide to do the cataract surgery, is totally different compared to when you're doing it with the clear lenses. Because Eagle study is telling that there is a benefit of the clear lens extraction, but what we have seen or what we have studied the Eagle study and what Dr. Ronnie has said, that there may be improvement in the quality of life because the patients were hypermetropic, and once you remove the cataract, then definitely the hypermetropia, because of that, the quality of life will improve. The pressure difference, if you see between the two groups, it is very minimal. Plus, there is a gonio changes which are missing. So I think in our scenario, in the Indian scenario, with clear lens extraction at this point of time, there are very few limited indications. Yes, definitely when you can plan for even the clear lens extraction, like if there is a high lens fault, though we do not have anything to study the lens fault, or on Aesocity also we do not have exactly which properly we do not get the landmark. But yes, there are few indication. If you are seeing the patient, there is a progressive change in the lens thickness, there is a high lens fault, sometimes you can know that clinically also, then definitely in those patients, or sometimes the patient who have changed from POAG to PSEG. So I think this type of patients you can definitely take up for even for the clear lens extraction. Otherwise, if the patient has cataract and you want to do as an indication for as a visually for visual the improvement, in those cases only we should do the cataract extraction.
Yeah, but that also you are not saying directly eagle, you are saying post-iridotomy. So we are not
Yes,
trying
yes, of
to,
course,
we are not
post-iridotomy,
trying
yes.
to use the eagle as published.
Yes,
So
yes.
when you said lens vault, Shamir, I think there's some publication from SNEC about the I think you have published
Right.
the normal variation in the normal population as opposed to angle closure, if I'm not mistaken. It
Yes,
has been some-
yeah. Thanks for remembering that one. It's quite an obscure study, but I thought it was quite useful at the time.
I thought it was 450 versus 800 or something like that, if I'm not mistaken.
Let me explain. So this was before the results of the Eagle study was out. Okay, it was many years before that, and we were supposing the situation where, let's say you had a patient with angle closure and you were thinking about lens extraction. If the vision was 6.6, you wouldn't do it. The vision was 6.12, you probably would do a cataract extraction for those eyes because the vision would get blurred. And the point is that the lens can thicken in size without the vision going down. That was the point. And hence, we did lens vault on those patients. And we said that if there was a high lens vault, yes, even though the vision was good at 6.9, let's say, maybe would go for the cataract extraction. If the vision was 6.9 and there was poor lens vault, nothing much of a lens vault, then we just elect to just watch or do LPI. So that was
Dr. Shamira, like, do you see the anterior chamber depth? Like, see for lens vault, if you are doing on Aesocity also, it is very difficult to identify scleral spurs sometimes. So is there any other parameters which you consider, okay, this is high lens vault and this patient will definitely benefit with the clear lens, or maybe early cataract, even if vision is good, like 6.9, sometimes 6.6 parts also.
Right. Well, Bhaskar and Arun and myself have done lots of studies on this area, and it seemed to be, that the lens vault was a good general one that we could all use and easily see and easily calculate that would be clinically useful. Some of the other ones are just not so easy to deal with. AOD, scleral width. There's anterior chamber area, anterior chamber volume. These are not easy to get hold of. So lens vault was a very accessible parameter that we could use.
Okay, thanks, Shamira. So let's go with some basic questions before we move into a little bit of advanced. So Amit, we have lots of general ophthalmologists. So first, would you just like to say that what are your indications, or in general what you would recommend that when you should do gonioscopy in the clinic? I'm not talking about glaucoma patient. In general, in clinical practice.
In general, in clinical practice, if I have one iris grade 1 on a certain examination, then I subject the patient to gonioscopy. Any patient who's diagnosed outside of any glaucoma suspect, I do a gonioscopy. All hypermetropes, I do a gonioscopy. And gonioscopy is a very important tool which has to be done and has to be taught in these following risk factor patients. Even if you suspect grade 2 also one iris, I would like to do a gonioscopy.
Okay. So in general, ideally we should do in every patient, but most of the what you said, we must do it, like glaucoma suspect or von Erich less than 1/4 corneal thickness. Any patient, even if you feel von Erich is 1 or deep, but if the pressures are more than 21, or if somebody is referred to you for glaucoma suspect or history of trauma, all these patients or hyperop, we must do gonioscopy. So in general, I think we all agree about what you said. The second,
quite a few times you have to remember that the angle von Erichs might be you'll get an open angle, but if the pressure is raised, you do a gonioscopy and you might find that the angle is closed.
yeah. So what we
have
should
to be
go by
both.
only von Erichs for the diagnosis of angle closure. Though the study done in CMC, I think Thomas was one of the author, that von Erich is less than 1 for IOP more than 21. You are very likely that patient is angle closure. But I think then also we must do gonioscopy to see what is the extent of synechiae, because that would be useful for the follow-up.
Dr. Bhaskar has to say something.
Yeah, Bhaskar, please.
Yeah, I think when we talk about gonioscopy, we tend to lean on to angle closure. I do not think that is the case, because to prove that the patient doesn't have angle closure, every patient has to go for gonioscopy. So that is the take-home message, actually.
Open angle
one of the statistically talking about, so when we looked at what is the kind of patients that are indicated and can have an outcome, we found that almost 20 to 25% of our clinic patients above 40 years of age tend to be these glaucoma suspects. So there is a huge number of patients in our clinic who have to go through gonioscopy. So that is something which we have to remember.
So I think regarding gonioscopy, Rajul, I think what Dr. Bhaskar wants to say that the take-home message that every patient who walks in your clinic first time must undergo gonioscopy. That is a part of comprehensive eye examination, and then you can decide in 6 monthly or yearly when you want to repeat the gonioscopy. I think that is the message to the general ophthalmologist that please gonioscopy is must.
So the second question is that your diagnosed patient is glaucoma, and we are not debating open angle or angle closure. How frequently you should repeat gonioscopy? And the Indian scenario where we have more angle closure compared to the Western population, should we follow EGS guideline or should we have our own criteria? Kavita, you want to say?
Yes, sir. Like we have a huge load of patients with angle closure disease. And I think once diagnosed as open angle, probably 2 to 3 years once at least we should repeat because it's a dynamic process. And these patients, as Dr. Shefali is insisting, there is a possibility like with aging also and increase in lens thickness, they can even go for angle closure disease. So once even after diagnosing open angle also, I feel like we need to repeat it at least 1 to 2 yearly intervals, or when we change, we see a change in the refractive error or so. And in angle closure disease also, like especially the PACS, when we are talking about observing the patients, I think every visit we should repeat. If we are following early, once in 1 year, it's better to repeat once in 1 year, like whenever we are following up the patients in that group.
So any other inputs? What Kavita has said?
So, Rajul, our protocol is that any patient with glaucoma, whether open or angle closure, we repeat gonioscopy annually.
Annually. Okay.
Annually.
And anytime there is a change in clinical picture.
Anytime.
Okay. I think that's right, because the lots of patient converts from open angle to angle closure. I think once a year in Indian scenario makes more sense.
Yeah, and just to add to that, anyone who has a post-dilated increase in intraocular pressure and progression, especially if it's happening at normal intraocular pressures while office recordings are normal. Those are 2 other indications that we use in our practice here.
Okay. So we all agree that how frequently, let me see now. What is my
I would also suggest that for every patient, it is better to use indentation gonioscopy, because many of us have the practice of using a single mirror or a 3 mirror, because you may miss a pseudo angle plateau iris, which is very common in Indian scenario.
Okay. So we haven't. I didn't put the questions, but I think yes, Bhaskar, your point is absolutely valid. Indentation gonioscopy, the technique of doing gonioscopy has to be proper, because if you keep the room light on, or if you keep the slit the beam improper, then you can impinge the pupil and pupil will constrict. So all these things, the basic things has to be properly used when we do the gonioscopy. That is before without any doubt. So
Rajul, what we need to underline is gonioscopy is not only for closure. Even an open angle could be a secondary open angle.
Yes, I think that was Bhaskar was trying to tell.
There is no diagnosing without gonio.
That the diagnosis of primary open angle glaucoma is diagnosis of exclusion. You have to rule out not only angle closure, but also secondary open angle and secondary angle closure glaucoma. So that is very clear. I think we all agree on that. My next question was how to use Von Erich, but I think we already have discussion that whether Von Erich is positive or negative, the gonioscopy is must. So let's not waste any time. That's very clear that Von Erich should not be used in routine practice. But I just would like to ask Ronnie that if the Von Erich is 1 and pressure is 15, in busy practice, if somebody doesn't do gonioscopy, is it okay? Because I would say no, but let's put it for the practical point of view.
I don't agree. I mean, at least a number of people on this panel come from very busy practices. And all our protocols are very clear that if one eric is 1, whatever the IOP, you're going to stick in a gonoscope.
So, and this is, I said that I don't agree with my question, but I just wanted to put for knowledge of general ophthalmology that putting gonioscope first time takes only 30 to 40 seconds and should not be excluded from your comprehensive eye examination. The next was we had some discussion when Bhaskar was talking about the role of PACT, and he's mentioned very clearly, or Aesocity, that Aesocity should not be used for screening. And then he also mentioned about his data on the progression. Arun, you have any other take on what Aesocity, when should be used, or what are your thought process when you would like to use in your clinical practice, or how you will use some
Yeah,
data?
I think I just emphasized that I tend to use Aesocity only when there's a disagreement between two experts. I also tend to use Aesocity when there's a patient education point of view.
Okay.
And very rarely I use it as a parameter to, like during follow-up, maybe 3 years down the line, if this patient has been a borderline angle status during the initial visit, I do order an Aesocity at 2 or 3 years down the line.
Just if I could add in something else from what Arun was saying as well, it's the fact that, you know, not everyone has ASOCT. It's expensive and difficult to upkeep as well. And I think, you know, we have to understand the limitations of the device as well. So it would make more sense for me to put the effort into training people to doing gonioscopy properly. It gives it a much greater breadth of information. The PAS, the pigmentation, all the other angle abnormalities that you can see physically. And I think that's where the interest should be focused.
Yes, I totally agree. But why I have kept discussion a little longer for Aesocity, because now with the newer spectral domain, OCTs is just a small attachment and is not that expensive. So not the separate machine, but with the spectral domain, ASOCT attachment is reasonably cheaper, and at least in metros, lots of people have and they use indiscriminately. So, and I just wanted to focus very clearly that ASOCT should not be used. And I think what Arun said makes sense, that if you diagnose using gonioscopy, that angle closure, from the patient counseling and explaining to patient the ASOCT image is very simple. It's very simple. So you can show that your angle is getting closed only from the explaining and teaching the patient. But one more question that I know, because we were discussing lens world, how frequently?
Raju, can I interrupt one because, you know, we all think that ASOCT image looks simpler, but unfortunately, the technician or the person who is doing it should be well trained, because if the image goes little off center, you may diagnose a wrong angle closure in that. So in fact, just few days before only, I was going and telling my own technician that when they are taking an image, the central corneal reflection should come properly. If they are not getting it, then they are getting a wrong image. So it is not easy to take an ASOCT image also. So that everybody, as general ophthalmologists, if you have an ASOCT, you got to tell your technicians to take it properly.
Okay. So, so the last question on ASOCT, how do you use lens vault, or do you use at all, or in individualized patient? Ronnie, want to take? Because I think Eagle could have used the lens vault or some lens parameters in their study, but they have not done. Otherwise, we would have some more information. But since that is not there, and I don't think we have any big studies. So, Ronnie, what is your take?
I think the lens vault is something which is, let me put it like this. The lens vault is a more objective way of seeing how anteriorly placed the lens is, or how much is bulging into the anterior chamber. But when you do gonioscopy, you actually look at how narrow your entry is, and you see how much over the hill you have to go. And that itself can give you an indication as to which eyes you think the lens is contributory. And the problem is that right now we do not have, let me say, a uniformly accepted cutoff saying that this is the level beyond which we would consider a lens fault as being very significant. And it may be different for different populations. It may be different for a Chinese population, an Indian population, a Malay population. So actually, I'd like your thoughts on that. I mean, Shamira, Bhaskar, Arun, one of you, because you see these three races commonly there. Do you notice differences in the way the lens vault is in these three populations?
Yeah. Shamira, Bhaskar, Arun, who wants to take that question?
So it's quite interesting. So we actually did the study on this. And I mean, just to summarize, I mean, one of the findings that we had, we found that lens spot was particularly important in the Chinese population. We found that iris thickness was important in the Malay and Indian populations as well. But of course, remember, in any of the Asian populations, we found that there was mixed mechanisms much greater than in Caucasian populations. So I think that's the very general view we can take about this.
Rajul, what I would like to say is taking into consideration only the lens wall. See, when we talk about clear lens extraction and higher lens wall, and that's why we want to do a clear lens extraction, we are affecting the quality of life because the surgical results in a patient with higher lens wall is not so good. I mean, you have to really master in that. So we wouldn't suggest that you have an Aesocity, calculate the lens wall, and if it is higher lens wall, I mean, we should operate for clear lens. Second thing was in a metropolitan city, what you mentioned, Aesocity is very common. Quite true, because it's a combo everywhere. Aesocity and posterior segment OCT is combined. But again, we have to give a take-home message to the general ophthalmologist. Like there are a lot of ophthalmologists in the metropolitan city still who practices glaucoma medications after taking the IOP with an NCT. So we don't want to give this message that don't do just an ASOCT and say it's an angle closure and do a PI. No. So as we mentioned, AT and gonioscopy, a dynamic gonioscopy is a must to treat glaucoma.
Yes, totally agree, Amit. And we all, again, we have reiterated again and again that ASOCT is not for diagnosis. In fact, Bhaskar also mentioned that not for progression also. And we also mentioned, Ronnie and Shefali, that Eagle cannot be used in day-to-day practice. I am just saying that in select patients, how will you use lens sword? So, this is the of not as a routine practice, but can we use ASOCT lens sword in a certain parameters, and in that case or in certain patient, that when will you use it? So that is the question. Not as a routine practice, not in every patient, that everyone is very clear. So and Shamira and Bhaskar and Ronnie, we all know that now they mentioned that there is no cutoff. So we need some more data. But Ronnie,
no, I won't say that there is no cutoff, because there was a cutoff around 850 microns of lens fault was the cutoff for diagnostic criteria, not for any surgical indication. I don't think lens fault is used for any surgical indication in any study. It was used for a diagnostic performance along with other parameters, along with some 5 other parameters. They have used it. So lens vault, I don't think it is used. It was checked for some surgical indications, but it was not proved to be good. So I don't think lens vault should be used as a surgical indication. Maybe for progression of the disease, in some cases, one can use this, because they noted that with age, the lens vault increases. That's the only thing.
Okay. Yeah. Thanks, Bhaskar. So I think everybody is very clear that lens vault in isolation, we are not using it. It has to be along with other clinical parameters. So next, Kavita, like POAG, the genetic association, is quite well published. What is your take on PACG? And the second, I think you have some data on the family screening.
Yeah.
So,
so we did
PACD only, not in open.
Yeah. So we did this study to like it was actually a sibling screening study. Since we have evidence on POAG, we wanted to understand what happened in primary angle closure disease. So as a part of the first part of the study, actually we recruited patients who came just for the refractive error as a control group, and we invited their sibling, and also we had 2 other groups. PAC and PACG we clubbed into a single group, and we had another group on PACS. So each group contributed 1 sibling, and what we found was like the risk of angle closure in siblings of patients with primary angle closure disease, whatever it is, PACS, PAC or PACG, the risk was 1 in 3. That was the risk we found in the siblings of patients with angle closure disease as compared to that of the siblings who had open angles. And also one more interesting thing we found is like the risk of primary angle closure or angle closure glaucoma in siblings of patients with PAC and PACG is almost thrice that of the population prevalence. So definitely we strongly recommend a family screening as we do for primary open angle glaucoma. So we need to screen all the siblings and the first degree relatives of patients with the primary angle closure disease. The risk is 1 in 3.
Okay. Anybody wants to add, or I think we all agree to what Kavita has said. So next, Siddharth, see, lots of discussion about, in relation to open angle glaucoma, the modifiable risk factor, the role of physical exercise and supplements, and now Tanu Dada's paper on the role of meditation. What is your take in relation to the angle closure disease?
In general, there are very few activities that affect patients with glaucoma. I think the common things that is applicable to anyone is avoid drinking lots of water. So our guideline is around 250 ml to 300 ml in an hour, not more than that. Any exercise or yoga that involves holding the breath should be avoided, and keeping yourself or whatever induces a Valsalva maneuver and breath holding should be avoided. We get musicians who play blowing instruments sometimes, so that is a situation that can rarely be encountered. And then I think what has also been shown is that wearing swimming goggles that put pressure on your eyeballs is something that may not be good for patients with glaucoma. I'm not sure if there is anything separately or differently applicable to patients with angle closure, but these are the common guidelines which related to the lifestyle.
Ronnie?
Patients who use
Bhaskar.
tricyclic antidepressants and similar psychotropic drugs, they tend to develop a secondary angle closure. So those patients need to be screened or informed that they can develop angle closure, because the psychiatrist doesn't tell them.
When the cold medicines also, which are commonly taken for cold, they can also precipitate angle closure.
Ronnie, your take on the meditation in relation to angle closure?
Yeah, see, in relation to angle closure, I have my concerns, because angle closure is ultimately an anatomical sort of abnormality in the eye which predisposes it to angle closure. We know that strong emotions can occasionally precipitate an acute angle closure attack. But whether the reverse is true, I don't think there's any physiological evidence that the reverse helps. So at present, I would not really, meditation is good for you overall, but I'm not sure there's enough evidence for us to say that it is going to benefit our glaucoma patients greatly, or whether it is actually going to help in a consistent intraocular pressure reduction that is lasting.
So I think the one point you want to say that the role in open angle glaucoma also is need to be evaluated by separate studies, because so far only one group has published the data, right?
Yes, I agree. We need more information, slightly more controlled studies,
yes,
both from the point of view of control of the meditation and the IOP monitoring.
Okay, so
I think we need to educate them about certain yoga postures which has to be avoided, especially in angle closure when we compare to the open angle. And coming to the cosmopolitan practice, we need to avoid them, tell them to avoid binge beer drinking, which is very, very important.
okay. So we'll just have few questions, then I will have a couple of cases before we stop. So I think the role of in which, Ronnie, just briefly, which Thomas, briefly, which patients you will recommend YAC PI in PACS, not in PAC, PACS, because now we know that, yeah, every patient is not required. In which high risk patient you will do
PACS? Because when you say PACS, there is no syndicate, there's no high pressures,
yes.
but you can have some coarse pigmentation which suggests previous apposition which didn't make it a syndicate. There I would err on the side of PI. Then I would go for a PI if a patient cannot come back for a follow-up He's going off to another country where there is poor medical facilities, something like that, going out of medical care, I would reduce the risk a little bit if I do a PI. And PI being a relatively innocuous procedure, I wouldn't mind doing it on those. That's about it.
The patient with family history of PSC.
Yeah, I would like to add, like saying, if one more thing the general consultants should bear in mind is if it is the fellow eye of a patient with an acute attack, or if it's a fellow eye of a patient with PAC, PACD,
If the fellow has definite
history of glaucoma related blindness, so I think always better to do
okay.
PI.
Repeated dilatation also if the patient needs.
Yeah, that also can be.
To a diabetic who needs repeated dilatation would also come in.
Yeah.
Okay. So then let me, I don't remember now question. So medical management is with POIG, PSAG, we had lots of discussion, is more or less same. So I'll skip this question. Any specific precaution if you're doing trap? Bhaskar, would not like to take that questions?
In angle closure with trap, especially with our patient profile advanced glaucomas, aqueous suppressants before the surgery and sometimes after the surgery, depending upon this thing to reduce the macular wipeout issue. And also on during the procedure, giving an aqueous suppressant earlier might probably deepen the anterior chamber to some extent as well. And sometimes when the patient is taken up in the OT, only we dilate in very, very high risk patients. Other than that, I think intraoperatively one need to take precautions to, avoid sudden decompression, and also, keeping the bottle height at varying levels, because the AC shallowing is quite a bit, and it may be preferable to utilize high molecular viscoelastics to avoid corneal injury as well. So those are some of the simple precautions one would take during.
So we'll take this little further. Arun, if there's a case of nanophthalmus, any specific precautions you would like to do along with if you're doing cataract or trabeculectomy?
Yeah, so nanophthalmus is known to have supraciliary effusion moment to decompress the eye. So I at least used to routinely follow doing decompressing sclerotomy. So at least 2 of those sclerotomies. So is what I would try.
Sclerotomy is sclerotomy.
Nanophthalmos, I would do sclerectomy with sclerotomy.
Two quadrant?
2 quadrants, yes.
Anyone else? Any other technique? Because this is what routinely we also do, 2 quadrant. But any other, Bhaskar, you have any other?
I think for nanophthalmus, it depends on what kind of procedure you use. Only a filtering procedure, then the sclerotomy alone would be sufficient. But most of the time in nanophthalmus, we also tend to do a lens extraction with the high lens Waltonol. So routinely, it has become a procedure of choice for us to do a zonulohylerotomy. With the retinal surgeon, we do it because these are very high risk cases, and the malignant glaucoma recurrence aqueous misdirection happens in these cases. So we tend to do vitrectomy as well as a zonulohylerotomy, making communication between the posterior chamber and the anterior chamber. So that works very well in these patients, and the recurrence of aqueous misdirection seems to be very less. So most of these nanophthalmic cases, we are tending to do that. Yeah.
Okay.
You're doing hyalodotomy needs to be done first. That is what you are recommending. And along with the vitreoretinal surgeon, we should do the cataract surgery in an ophthalmic patient.
That is right. In most cases, there are some exceptions, but in most of the nanophthalmic proven nanophthalmic cases, we have done it. And recently, some of those patients I'm seeing, even with after axial length between 18 to 21, some of them are a bit high risk. So we need to see pre-operatively, we need to evaluate them much more clearly and make our operative plan accordingly with the vitreoretinal surgeon.
Shamir, I want to add anything about?
Yeah, I mean, we've had many conversations with Bhaskar and Aaron about this particular situation, but I think it's very important to note that the posterior segment is not the same as, you know, a normal eye, and the dimensions are not the same. So they, even though a experienced retinal surgeon can run into difficulties. I remember one case where they went through into retina thinking that they were going through pars plana, because the, you know, anatomy is different.
So nanothelmus are difficult cases to handle. So I think, but one message is very clear, that those high risk cases is better managed by the glaucoma experts in general, including the angle closure also, where the cataract surgery is difficult in general. So now let's see. We are running a little late, so I'll just shift to the cases. My slide visible, na? Okay.
Yes.
Just one quick question, Bhaskar. Do you do iridoplasty in all plateau iris, or what is your indication?
I do not do iridoplasty at all.
But
there was one study which was done in Singapore. I think Arun led that. So he can give more comments on that. Iridoplasty does harm to the corneal endothelium as well as to the angle. So iridoplasty is very, very rarely done. Not for plateau iris syndrome, but in a situation where you cannot, in an acute angle closure situation where some very, very rare indication it is. So most of the time you should be able to manage with medical management in such situations. But I think iridoplasty as the procedure for plateau iris syndrome, I don't do.
Okay. Arun, want to add anything?
So we did not exactly do iridoplasty in plateau iris syndrome. Plateau iris syndrome by definition is eyes that go into acute IOP spike following an iridotomy and have a plateau configuration. So we did enroll our patients with plateau iris configuration and did iridoplasty, yes. The overall efficacy of the iridoplasty in these eyes in opening up the angle was very limited, and it was very transient. So in general, the study did summarize that the efficacy of an iridoplasty was very limited. And of course, there's a worry, though the study itself did not show any clear harm to the endothelium, we do continue to worry about it, especially because the eyes being shallow. I think these eyes should always be, if there's a real need to do something, it's a reasonable option to consider cataract surgery in these patients if they need it, rather than, I would lean towards that rather than a iridoplasty.
But
including an eye, yeah.
Then I go ahead. Then I'll just
including an eye that you think is a plateau iris syndrome. Plateau iris syndrome, like I said, is a specific situation wherein you dilate an eye with plateau iris configuration, and despite an iridotomy, they spike into the 50s and 60s. So in such eyes, I would recommend a lens extraction.
Okay. The only thing that RCT you did on that SLT, I think you didn't publish the long-term data. I think
probably no funds.
I think it was only short term.
Yeah, it was, I think, 1 year outcome. So I don't think we followed up further. Yeah.
Okay. Dr. Siddharth wants to add something.
Yes, Siddharth, please go ahead.
Yeah. Of late, pilocarpine has not been available in the country in any form, either as a single agent or a combined agent. So here, I think there is a significant role that iridoplasty has had to play. And the simple test on whether the iridoplasty is going to help or not is using pilocarpine. In all the patients that pilocarpine has worked earlier, iridoplasty will also work. And of late, quite a few of our patients, plateau iris who were on pilocarpine were coming back with raised intraocular pressures, and we have had to do iridoplasties for them. So it works definitely in patients where pilocarpine has worked. And given the fact that it's not in supply right now, we might be doing quite more of these.
So I have a question for Dr. Siddharth. Like pilocarpine, suppose if you start the pilocarpine, so how long would you like to give the pilocarpine, especially considering that patient has cataract and future you may have to do the cataract surgery?
I think...
which one would you choose? What Dr. Arun is telling, like a lens extraction versus the long-term pilocarpine.
Right.
Because
So
you know,
that-
doing cataract surgery, the patient sometimes comes with the patients who are on chronic pilocarpine therapy. The pupil is so miotic and it becomes a nightmare for her. So basically, it is for that reason I'm asking, because we have to deal with this type of patients.
The good thing about the pilo is it really kills the iris and makes it so atrophic that probably just stretching with Kuglen's hooks is enough most of the times, but not a pleasant situation. I agree with that.
Okay.
If you remember, when we started our practice in the 1990s, we did see patients who were on pilocarpine for about 8 to 10 years. And I don't think it goes into, the pupil goes into this meiotic status very, just over a period of few years, about 2 to 3 years. It takes quite a while for the pupil to, though the dilatation may take longer, a permanent effect on the size of the pupil is probably needs a very long-term therapy with pilocarpine. So I remember seeing patients in 1990s who were on pilocarpine for about 8, 10 years, but the cataract surgery was not so challenging with regard to the dilatation status. So I think it's a reasonable option if you want a temporary non-invasive procedure to consider pilocarpine.
Arun, I think in 90s we had 1% available, at least in India.
Yeah.
Yeah, 1% was much better than 2%. I think
Right.
the Mios is by 2% is much more. The 1% was very good alternative to iridoplasty. But let's move. Ronnie, your final concluding remark.
Yes, discussion. Yes, we should start if you want to
Ronnie,
take
your
any
final
discussion.
concluding
Yes,
remark
we are running short
on
of time.
iridoplasty, and then we move to the cases.
See, iridoplasty in many eyes seems to work short term. The long term, how well it works is, I think, the concern that most of us have, and that's the reason most of us don't use it that often. And pilocarpine, if you use it, as you get otherwise. So I think that's the only statement I have to make.
So, yeah, thanks, Ronnie. So, a few cases, and this is the one which I wanted to highlight. This is Shefali's patient. She was open angle glaucoma, which converted on angle closure over a period of 5 years. The gradual shallowing of anterior chamber. She also, despite patent PI, had a increase in synechia, and she developed early cataract. And she had some progression on perimetry. She was on maximum medical treatment, all the 4 molecules. And this was the lens vault, 850, 820 and 850 in right and left eye. And this was the lens thickness on in A scan. So what will you recommend in this kind of patient? Shami, you want to take this question? So she converted from POA to PACG. She had progressive acid shallowing, increase in the synechia on maximum medical therapy, some amount of progression, and this was the lens parameters.
Vision was good. I think that also you should put vision was good. So basically, here the indication was not for vision. It was basically for this lens thickness and this thing. So in such cases, how would you manage? How would you go?
Yeah, so it's a tough one, actually. I mean, it'd be very easy if there was a cataract there. You know, we would just go for phaco or maybe phaco plus GSL. But in this particular case, you know, there's something progressing here. And, you know, it's unusual to get that situation from open angles to go to closed angles and also PAS. And in this kind of case where there's something progressively going on, I wouldn't be surprised if there's something like, for example, a sublux lens. So I think you should do imaging to find out if there's that kind of situation, something secondary going on, because it's not normal to have this happening.
Okay.
So we did Aesocity and that showed high lens thickness. It was more than 800. So so any other opinion, like how would you progress, Dr. Bhaskar, Dr. Arun? So basically your indication was not vision. So in this case, this type of cases, how will you like your lens thickness is, yes, it is on higher side, and Aesocity. Now again, they're like, as we discussed, there is no exact cutoff where we can decide only based on Aesocity, based on the lens vault. That yes, this patient needs cataract surgery. So how will you proceed in such patient?
I agree with Shamira that I would like to know what is unusual going on there. I would prefer to do a UBM to check for zonules as well as the position of the lens. One. Second thing, of course, I would like to know whether they are visual fields wise progressing or not. If they are not, I would probably keep a careful watch and would wait for the patient to become significantly visually impaired and probably do an early lens extraction with or without the glaucoma procedure, as it is at that particular point. There is likely progression. I think that there is an indication there for surgical intervention. So it depends whether it is going to be combined. Sorry?
Yeah, one second. We didn't do. Sorry, yeah, Rajul, you tell. You go on.
So, Bhaskar, she progressed. She on maximum medical therapy, high lens wall. So the question is that whether only cataract or cataract plus glaucoma surgery.
Is there a cataract?
She had early cataract. See,
NS1 plus something, not more than that.
I would go for a combined surgery.
I would prefer a combined.
Rajul, you got a 68-year-old person with early cataract where you think the lens vault is at risk. I think you got enough indications to go for a
combined
cataract extraction with IO. Because you're on 4 medications already.
I would go for a
post-cataract eye is comfortable compared to a post-trab eye. That would be the other reason to think about it.
Okay.
I would be cautious about doing glaucoma surgery here because the visual field is still very good. If you can get away with a phaco, maybe a phaco plus GSL, it's much quicker and easier for the patient.
Can I say something here?
Yes.
Yeah. So like this is the case that why I didn't do UBM, because this patient I was following for 10 years. And after within this 7 to 10 years, she developed that, propiogy to PSAG to then from one medication to 2, 3 and this thing. So I was seeing her and she was highly, that A type of personality. So here seeing her lens thickness and her AC was so shallow. I think Rajul, you haven't shown the AC findings. It was less than, I think 1.6 or something. So I was seeing that, it was becoming difficult that how I'm going to put my probe also, phaco probe. So in this, then I decided, okay, you would not take a call. I asked the patient because her vision was good. She was never complaining for the vision, that here I would like to intervene, not because of your vision or anything, but because it will become difficult for me to operate in later on if you demand that give me the good results. So here in this patient, since the visual field, yes, it was showing some changes, but it was never that her vision was good. And if you see the fields that were not very advanced damage. So I took a call and I did only cataract surgery. And even after now, I think it is now nearly 3.5 years, patients' pressures are between 12 to 14 and only on one medication. I did only cataract surgery in both the eyes. Maybe I may have decided for combined, but seeing her this A-type personality, and I was really thinking she will come to me, okay, why I am having this irritation, why I am having that thing. So I decided only for the cataract, and especially one of the reason why I decided, because when we are doing with phaco, we are mainly keeping this conjunctiva virgin. So I think we can take up the trap. So I told very clearly that if I want to do glaucoma surgery, I will do later on. So I think, but it has done, worked very well in for last 3.5 years, rather than all the 4 medications. She's only on one medication and she's very happy and making me also happy every time when she comes.
So, any take, should I move to second case? Bhaskar, you want to add anything? Final concluding remark?
Yeah, I think a good job there for that patient, but may not work for every patient. It's good sometimes to keep it to different procedures, like do a phaco first and then or the other way as well. But I would have erred on the side of combined procedure in that case.
I think counseling.
I agree with Bhaskar.
Counseling is very important. We must explain the patient that what are the pros and cons before we take the call. And every patient is different. Of course, this patient would have required trap. That's absolutely right, Bhaskar. So let's move to the second case. One of my old patient came with redness, no history of trauma, no systemic disease other than hypertension on treatment. She was on ACE inhibitor. 6/6 vision, IOP was 42/34, normal pulsatile Mayer, and this is his straight line finding. Dilated episcleral vein. On gonoscopy, she has blood in Skems canal with open angle, normal pachymetry, disc and field normal, there was only 0.6. Peripheral retina normal. I got it rechecked by retina specialist. This is oculoplasty finding about the retropulsion, vascular maneuver, brood negative, and this is Hertel's measurement at 94 2020. So no skin lesion. This is what I thought. My probable diagnosis is open angle glaucoma secondary to increased episcleral venous pressure. Now question is, how will you investigate? What are the possible things we have to keep in mind? Siddharth, you want to take that question?
Yeah, muted Siddharth.
Siddharth,
Sorry. So definitely a patient with raised episcleral venous pressure, all signs are there. Probably will need an imaging, and especially if you keep the low flow cavernous fistulas in mind, it will help if you have a contrast while you're doing the imaging.
okay. Any other thing?
Yeah.
Shamira?
So, I was just going to add that, I think if you, even despite the signs, the lack of retropulsion, etc., no bruin, and all that, you can still have these small CCFs. And if you do a CT scan, which is quite easy, you could see the dilated superior ophthalmic vein, and if that's there, then you can go on to do a 4-vessel angiogram. I think I would still have a high degree of suspicion because it's ultimately surgically amenable.
Okay. Anyone to add anything? Bhaskar, Amit, Kavita?
Rajul, what was the retinal vessels like? Were they also tortuous?
No. Retina was absolutely normal.
And Rajul, was this unilateral?
Pardon?
Bilateral.
Was it bilateral? Okay.
Yes,
So if it's bilateral, keraticocaverous fistula
is out.
Fine. Yeah, it's very rare, but no harm ruling it out. You ruled out the other causes like Sturge-Weber or other causes of episcleral. So there's one small entity wherein they labeled it as idiopathic raised episcleral venous pressure. I guess if you have ruled out all the other things, because it's bilateral, I'm a little circumspect that it is rarely associated with the keratico-cavernous fistula, that is, even if it's low flow. So you probably will have to deal with it as the idiopathic cause, which is described by Rich. Basically, you treat it with medically as needed, or then you, if at all. I mean, I'll let you take over if you're talking about management.
I just did what I did.
Yeah.
Because
I also wanted to talk about the D scan and the thyroid profile, which you already mentioned.
To rule out the vascular malformation, again, as Arun was saying, bilateral, so very unlikely.
One thing that I heard, I had attended a case somewhere where there was a mediastinal tumor which was causing a superior vena cava syndrome.
Yes,
and had led to a...
Absolutely right, Siddharth. And we got the CT chest also done. So MRI, digital subtraction angioplasty to rule out the low grade, because sometimes MRI can miss it. So DCA is better. That is what the radiologist was saying. So that also was normal. As Siddharth was saying, to rule out the tumor at apex or primary pulmonary hypertension, we send it to physician. That also was normal. So as Arun was saying, this is the end result. The idiopathic dilated episcleral vein. The only thing, Arun, this lady is 68 years. What is described in the literature about the dilated idiopathic is in 30s and 40s. So that was the only unusual thing. But again, if it's a small low grade, it can get closed intermittently. So that is one thing.
Yeah, that's what I wanted to tell. This patient need to go through this DSA probably, again sometime later. You may pick it up at one point.
So she had a couple of visits. She followed up with me for 3-4 years, and she had couple of DCA, and it is normal. The pressures were not controlled with the medical management, so we opted for trabeculectomy, and I had decided to do to treat like the all dilated episcleral vein and nanophthalmos. So we did the sclerectomy with sclerotomy. The only thing I did different, or maybe I should have done the sclerotomy, I didn't open up before the trap, and I opened up the sclerotomy after I did the trap, and she developed the effusion on table. Uh, we subsided on conservative management, but that was the only thing I think I should have done. The sclerostomy, open up the sclerostomy before I did the trap. That was, I think. Any other suggestion? Or will you do trap, or will you consider primary tube in this kind of patient?
No, the basic point is you're decompressing the eye. The moment you decompress anyway, whether it's tube or trap, you're going to have the effusion. So I think it's ideal to perform the sclerotomies before you enter the anterior chamber. And effusion can happen on table, and there'll be egress of fluid through the sclerotomy. The only thing I don't recommend for the raised episcleral venous pressure is a sclerectomy. You don't need that. You need it only for non-ophthalmic eyes where the scleral fibers tend to contribute to pathology. For a raised episcleral venous pressure, just open up 2 quadrants. You can of course cauterize the lips of the sclerostomy so that if there's any fluid that needs to egress, it will egress. And even the post-operatively, you can still develop choroidal effusion, but the choroidal effusion will regress quickly because of the exit tract that is available through the sclerotomies.
Yeah. Good. I think so. We are already overshoot by 10 minutes. We'll close the session. Before that, I will ask our president to give the vote of thanks.
Yes, yes, absolutely. Wonderful webinar. I think the panel discussion is the icing on the cake. Of course, the speaker spoke so nicely. In-depth discussion of the panel, small little points are so well covered, and that is going to be very, very useful for the general ophthalmologist. Thanks, Rajul and Shefali, for a wonderful session throughout the month that you have been holding it, and this was one of the best webinars that you have conducted. We have for faculty who had well covered all the topics which is required under secondary glaucoma and of course the angle closure glaucoma. MOS is really thankful to you for having this for all of us. Thanks a lot all the faculty members who have taken the efforts to join on a Sunday evening and made it memorable. Thank you very much.
We are thankful to MOS, sir, and we are thankful to you also for really motivating us. And we are thankful to all our speakers. We are thankful to Eldod, who gave throughout our series. They gave flawless platform and they helped a lot.
I would like to make a small comment here.
Amit.
I would like to make a small comment since we have the president of MOS on this platform and I being representative of AIOS. I welcome all our international speakers for the upcoming AIOC conference in Mumbai in June 2022 this year. You all are welcome. It will be a great pleasure to host you all in Mumbai, and we have Dr. Jignesh. So on behalf of MOS and AIOC, I open up this invitation to all of.
So on behalf of Mumbaiites, we are welcoming you. I mean, on behalf of Mumbaiites, we are welcoming all of you.
Yeah. So Arun, I'm waiting for a positive reply. Once it opens up, you are in.
It is from the second to the
Thank you
5th
so
of
much.
June. 2nd to the 5th of June is at a very nice place. The Reliance Center which has come up is one of the best centers, I think, in Asia at least. So don't miss to attend it physically. That's happening after almost 2 years. So I request everybody to be part of this mega conference. Of course, it's at a short notice because of the COVID protocols, which had just opened up after 15th of February. So I hope to see you, all of you, at this lovely conference.
Thank you everybody.
The entered people, if we want to run the video.
And a gallery view shot first. Have the videos on and have it before they run the video. Yeah,
picture clicked, sir.
Yeah, so just run the video if you is ready.
Yeah, run your video now.
thanks. So this is the last of our series. I would like to thank all my friends, panelists, speakers, and especially Samira and Arun, because I think it's already more past 11, if I'm not mistaken.
Yeah.
Thanks, Samira, and sparing
My
your
pleasure.
late
Thank you very much for the invite.
Yeah. So all and see you sometime physically in future. Bye bye. Good night.
Hey, good night.
Right.
Thank you. Good night.
Thank you, Shefali.
Right. Good night. Good night.